And next, let me move to the last topic of today, the tips and technique in minimally invasive gastrectomy launched by Professor Tsuyoshi Etoh. As mentioned in the morning, the professor worked at the Faculty of Medicine, Oita University. Please, Professor.
Thank you, Chairman. Thank you very much for the kind introduction again. Okay, let me talk about the second topic in my talk today. My topic is the tips and the technique is a minimal invasive gastrectomy for advanced gastric cancer. This is the content in my talk. The concept for surgical safety based on the anatomical landmarks in minimally invasive surgery, MIS, for gastric cancer. And the second is the technical tips of the lymph node dissection in a minimal invasive gastrectomy for AGC. The first topics. This is the technical difficulty is lap gastrectomy for advanced gastric cancer. The narrow working space were wet operating field and unclear border between the organs due to the adhesion or tumor invasion, and weakness of the organs and easy to oozing and so on. The first, I'd like to give you the key message. I think the understanding the opposite is very important. For example, the tumor large or small. The size and the volume of a target region of such a tumor lymph nodes. So understanding is very important. Next, the wide and narrow space. We have to make the surgical field exposure and the space or operation manipulation for surgical safety. The third is hard or soft. We have to make sure the condition of the tissue to be manipulated or grafts. Finally, in the strong, weak, and traction. The safety traction is very, very important in the minimal invasive surgery, in not only lap surgery, but also the robotic surgery. So the understanding of the opposite is very essential, I think. And next message is anatomical landmarks for surgical safety. The first is outermost layer-oriented approach. Many previous speakers talk about the outermost layer. The next, tracing the dissected layers of mesenteries. I mean, the mesenterectomy, gastric mesenterectomy is very important. I mean, gastric cancer surgery, as well as colorectal surgery. The concept is very important, and the unblocked resection. And finally, dimpling lines as anatomical landmarks. Dimpling lines are our team is propose this concept. And the importance of understanding the surgical concept and mastering surgical modality, lap or robotic, is essential. I'd like to explain the dimpling lines. Dimpling lines means the depression formed between the pancreas and the surrounding tissues. This pancreas is surrounded by mesogastrium and the duodenum and the transverse mesocolon. And the depression was formed around the pancreas. So we named the dimpling line. Right side shows the indication of the dimpling lines. So we developed the indication by AI. So we are now just research level. The green lines we named the dimpling line between the mesogastrium and the pancreas. And the red line formed between the pancreas and the transverse mesocolon again. And the blue line is not indicated in this video. Blue lines, the dimpling lines between the pancreas and the duodenum. This is a dimpling line in the infrapyloric area. Next, this is the suprapancreatic area. In this area, it's very simple. This is a pancreas, and this is a gastromesothelium, including number 8 lymph node, or number 9, or number 11 lymph node. We can see the dimpling lines indicated by green lines, like this. So what we are aware of during surgery, we think this is a transverse mesocolon. First, we find out the depression between the pancreas and the transverse colon. We name the DTP. And the next, we will find out the DMP, depression line between the pancreas and the gastric mesenterium. Dimpling line means the plane and layer. As I said, we are developing the digital transformation of surgery using the AI navigation surgery. Yes, and this AI system will contribute to not only the surgical safety, but also education of the young training. We are now developing. Okay, let's talk about, let's move to the technical tips in the minimally invasive surgery. I prepared some short video, the type 4 gastric cancer and the suprapancreatic lymph node dissection in the splenic hilum and EGG cancer, the conversion surgery and the robotic surgery. Very short video. This case is a type 4 advanced cancer with neoadjuvant chemotherapy and the BMI 36. So you can see the blue river here. That's very fat patient. So you can see the shallow depression between the pancreas and the gastric mesenterium. We name it the dimpling line DMP. And after that, the right epigastric vein exposed and cut. And then I move to procedure. So you can see a shallow depression between pancreas and the gastric mesenterium. And finally, I cut the right gastric artery and then cut the infrapyloric artery. The completion of the resection, the mesentery, complete mesentery. This is a final view. In this case, there is no minimum bleeding, 1 or 2 milliliter gram during surgery. So next, the suprapancreatic lymph node dissection. This case is advanced gastric cancer located in the gastric upper body. The lymph node dissection is continuous along the splenic artery like this. I always teach the young junior staff, so the procedure should be the step by step, one by one, for gentry. The mobilization of the gastric mesenterium like this, and then we move to continue to the lymph node dissection around the splenic artery and the splenic vein in the splenic hilum. Of course, lymph node dissection of the number 10 is still in debate in Japan. But technically, as the lymph node dissection of number 10 is feasible. Even not only the LARP surgery, but the robotic surgery. This is the final view after the lymph node dissection in the splenic hilum, preserving the pancreas. This is standard treatment. The next technique for the EGJ cancer, I cut the phrenic artery and then they move to the splenic hilum. They expose the around the esophagus like this. Now, sometimes I cut the diaphragm to make the good operation field like this. And first, the upper side performed the upper side the lymph node dissection, and the lower side, and the left side, and finally right side. This is my procedure. In this patient, in this case, the tumor located just on the EGJ, and the tumor invasion is maybe the 2 centimeter diameter. So we have to cut the 4 centimeter from the EGJ to keep the 2 centimeter as a safety margin. Around here, we named the lymph node 110. Yes. Regarding reconstruction after EGJ cancer, there's 2 options. One is esophagogastrostomy using the stomach, and the other is esophagojejunostomy, or interposition, or double tract method. If the cut the higher position, we prefer the esophagojejunostomy, double tract method. The next, suprapancreatic lymph node dissection in the conversion LTG. This patient's age is 26 years female, squamous type gastric cancer. This patient had a type 4 with a peritoneal metastasis, and then she received the SOX and nivolumab regimen. After the 8 course performed, there's no evidence of the metastasis, and we decided surgery. During the surgery, fortunately, there's no peritoneal metastasis and ascites, so they continue the procedure. The first, we dissection around the esophagus or the upper side of the stomach. And everywhere the hard deposit was there after the chemotherapy. The first, we completed the lymph node dissection around the esophagus and the upper side of the stomach. We named the superior approach. And then to move down, going down to the lymph node dissection around the lesser curvature side. This is the right gastric artery here. And then move to lymph node dissection in the suprapancreatic area like this. The tissue is so wet and hard, and the lymph node is also hard due to the lymph node metastasis. Firstly, as I said, the understanding of the deposit is very important. Where is the safety area? Where is the safety zone on that, and the wide and narrow space? We always continuously make sure this opposite, understanding the opposite. And again, the important thing is the one by one or the step by step intergentry. When we do that, there's no bleeding. So we name the white surgery, no bleeding. Not red, white surgery. Of course, there's no evidence of the advantage of the minimal invasive surgery in the conversion surgery. And of course, there's no survival benefit at this moment, so we have to continue accumulate the data, the feasibility of this procedure in the conversion surgery. But anyway, we at least we confirmed the technical feasibility in the surgery. So this is the final view of the lymph node dissection in the conversion cases. Okay, next, I'd like to talk about robotic gastrectomy. In our university, we have two systems. One is the Da Vinci system, and the other is the Hinotori. Hinotori is made in Japan. Now, of course, the Intuitive is a big country, big company, and the Hinotori is made in Japan, and this system is gradually, the number of this system is gradually increasing. But nowadays, many companies develop the robotic system. I don't know the situation that Thailand, but maybe from now, the robotic system is increasing in the worldwide. As you know, in robotic surgery, robotic gastrectomy, there are several advantages. So multi-direction or fixed operation field and a 3D view, and so on. But on the other hand, this system very high cost, and some disadvantage for young education or young training. Well, that's a big problem in Japan. But anyway, the concept of this procedure is just the same of the rapid gastrectomy, I think. Of course, the modality is different, but concept is the same in the minimal invasive surgery, as a minimal invasive surgery. In robotic surgery, the traction using the force arm is very important to make the safe operation field. The retention is very important. And Professor Uyama is at Fujita University. They developed the technique, the double bipolar method. Right hand double bipolar, the left hand also bipolar, double bipolar method, using the monopolar. On the other hand, Professor Ujin Hyun in the Yonsei University in Korea prefer the monopolar method. I think in Japan, the majority of the technique is the double bipolar method in Japan. But both procedures are okay. Just depend on the surgeon preference. So this patient has the advanced gastric cancer in the proximal gastrectomy, proximal stomach. So I performed the proximal gastrectomy. The stable operation field was done. This case is a DG. I'm sorry. Okay. This is the last video, proximal gastrectomy. The concept is the same. This patient has the accessory left hepatic vein, so I decided to preserve the left hepatic artery. So during lymph node dissections, outermost layers concept and total mesenterectomy is important. During the outermost layer approach, we have to preserve the nerve around the artery. So such a precise procedure is very suitable in robotic surgery. As I explained in the morning session, in Japan now, the randomized control trial is going. The feasibility of the robotic surgery compared to lap surgery. The primary endpoint is the occurrence of the pancreatic fistula or intra-abdominal abscess. But in retrospective data, there is no difference between this procedure. But anyway, so we have to accumulate the solid evidence. So maybe the next year, so we will know the result of this trial. Okay. So this is the final slide. I'd like to propose the key concept in the MIS for gastric cancer. The first, to make sure that the landmarks, the demineralized outermost layer is very important. And to keep the adequate operation field continuously, so indication of the anatomical landmark is also important. And finally, to acquire the basic skill for both technical and oncological safety is the most important. Thank you very much for the kind attention.
Thank you so much for your excellent talk, Professor Etoh. Is there any question or comment from the audience, both on site and online? Is there any question? Okay. I have some question about the robotic gastrectomy, Professor Etoh. About distal gastrectomy or proximal gastrectomy, the origin of dissection, do you decide to perform which area first? Which is the difference between distal gastrectomy or proximal gastrectomy in robotic surgery?
Thank you very much for that question. Of course, in distal gastrectomy, the first with the greater curvature side and then the lesser curvature side and the suprapancreatic areas. This is the standard procedure. But if the tumor is located the very upper side or more advanced gastric cancer, I prefer the first, the greater curvature, lesser curvature side or suprapancreatic side. So, superior approach. I prefer.
Superior approach. Thank you so much. And I have a question for Dr. Kitinat about the reconstruction. In your opinion, when you like to perform B1 anastomosis or Room-wide anastomosis, how can you choose the proper anastomosis of reconstruction in your opinion?
Okay.
For after distal gastrectomy.
Okay. ครับ Okay. For distal gastrectomy, I prefer the room wide because I think it's more easier than the B1 anastomosis. In my opinion, because I familiar with the in Thailand we have the more many cases of the infiltrative cancer that we have required for a large margin. When we perform even the distal gastrectomy, the stomach remnant is the small portion of the fundus that we cannot perform the B1 because the tension. But and if you want the technique for the when you want to perform the B B1 such as the delta shaped anastomosis that I show, you have to mobilize the duodenum more than a little bit from the head of pancreas that facilitate for the you make the anastomosis. So when the reason that I use the room wide prefer room wide because the one I avoid to mobilize the duodenum and even the from the fear for the injury or the achieve the negative margin and for the reason of the tumor that require the large 5 centimeter margin, so I prefer the room wide.
Thank you so much for your detailed answer. Okay, today we have learned a lot about gastric cancer from basic to advanced, especially in surgery side and of course in staging and chemotherapy side. Now we are going to end the session. Let me invite Professor Asada Metaset to close today's session.
Thank you. Today's lecture was very interesting. I hope you all get the knowledge and all the techniques of gastrectomy to use in your practice. On behalf of the organizing committee of MESDA Thailand, I would like to thank Professor Etoh and other speakers for giving us these wonderful lectures. And I would like to close today's lecture now. For those of you who will join the workshop, we will meet at Sirirat Hospital tomorrow. Thank you very much for all participants.
Thank you so much. And for the on-site participants, of course, we have the hands-on workshop tomorrow. So we have the special session, the topic of optimizing patient outcomes through the safe use of Power Seal, launched by Andy Poon from APAC MSA. Please